So we can start now. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Ladies and gentlemen, today we are so proud to be with one of the most famous generational makers in ophthalmology. Today we are so lucky to be with one of the most influential figures in ophthalmology. That is Professor Harminder Dua, whom the cornea has been waiting for one of his many fingerprints that made history, yet the Dua's layer. He is an exceptional cornea surgeon who has made hundreds of contributions to research, publications, conferences, and discoveries. He is an outstanding cornea surgeon who established unique classifications that have changed the methods of diagnosis and treatment. I will not talk about the certificates he obtained or the positions he occupied, as he is more famous than that. I am sure that no ophthalmologist doesn't know, or at least has heard of Professor Dua. Far from science and academia, today we are with an international human icon who has white hands in helping others. Perhaps my personal experience is the best proof of that. About 10 years ago, I had the honor to receive an offer of sponsorship from Professor Dua to be one of his students, but I wasn't lucky due to some circumstances. Please join me to welcome the great teacher, Professor Harminder Dua, and thank him for accepting the invitation and devoting a part of his busy time to teaching us despite his travel. At the same time, I would like to welcome and thank the panelists who accepted the invitation, Professor Tariq Qatamish, Dr. Nancy, and Dr. Gueda. And I would like to welcome three of Prof. Dua ex-students who had their PhD under his supervision in 2010 and now have become consultants in the UK in their fields, Dr. Munir Atri, Dr. Ammar Miri, and Dr. Muhammad Al-Aqaba. So thank you very much, Professor Dua, again, for accepting the invitation, and the stage is yours.
Well, thank you very much. First of all, happy Ramadan to all of you and to many, many of our colleagues who will be joining in today. For the first time, on the first day of Ramadan, we went to a colleague's house and I had iftar with them, and I joined them in the prayers, which I found were very similar to the prayers we do in the Sikh temple when we go on our knees and bend our head and touch the floor in front of our holy book. So that was a very interesting and exciting experience for me. And I thank you very much for your very generous and kind introduction and for your invitation to be part of this academy, which is gaining in popularity, and I'm sure will become a very sought after academy to attend. I will now share my screen with all of you, and hopefully everything goes well. Just change this to slideshow and we can start. So that's the title, the Dua's layer or the pre-Descemet's layer, clinical and surgical applications. I've divided my talk into two parts. The first part will be clinical applications and clinical pathology, and the next part will be on the surgical applications. I'm not going to go into the details and the controversy of whether this layer is there or not. Just presume it's there, and hopefully I'll be able to show you a bit more. Starting with the basics, so just to show what a type 1 big bubble is, this video shows how air is escaping at the periphery, as you can see, these bubbles, and a nice central bubble forms, which goes for about 8 millimeters in diameter, starts in the center and remains localized to the center. That's an example over there. As against this type 2 bubble, which starts at the periphery, as you can see here, that circular movement of air, a very thin wall bubble, but it extends across the entire posterior surface of the cornea. And again, you can see this other example, you'll see that two little bubbles starting, one at one end, one at the other, and they coalesce to form a large bubble that covers the entire posterior surface of the cornea. And we call this the type 2 bubble. This bubble is made of Descemet's membrane only. The type 1 is made of the pre-Descemet's layer and Descemet's membrane. And then often we get mixed bubbles where the two are associated. Some people call this type 3, but it's probably better to call it mixed because it's a combination of type 1 and type 2, as you see here, and the central type 1 and a fairly large horseshoe-shaped type 2. Now, in the past, it was said that this is due to a split in the Descemet's membrane, but clearly, if you take the Descemet's membrane from a type 1 bubble, a type 2 bubble, or a mixed bubble, and you do histology, you will find the banded, non-banded zone and the endothelial cells, and there is never a split. So that's some of the basic information. Now, on the basis of this, let us look at some clinical applications and clinical pathology. The OCT of a Descemet's membrane always shows a double contour parallel tram track line. So the difference in refractive index between the fluid here anterior to the Descemet's membrane and the anterior surface of the Descemet's membrane causes a very sharp hyperreflective line. Then there's the band, actually the Descemet's membrane width, which shows a dark line. And then again, the change in refractive index from the endothelial surface to the aqueous produces another hyperreflective sharp line. So this double contour line on OCT is a feature of one structure, which is the Descemet's membrane. And even in the living human eye, by ultra high resolution OCT, Bezever et al. Showed that you could see beyond the last row of keratocytes, which are the red arrows, you see the pre-Descemet's layer, which is here, and then this double contour line of the Descemet's membrane, which correlates nicely with the histology, which is shown in the right panel over here. Now, let's look at these pathological conditions and how clinically, some of them, you'll be surprised to note we got it wrong for more than 100 years. Samuel first described Descemet's membrane detachment in 1928 as a detachment of the Descemet's membrane. A recent 2020 article in the survey also said it is a detachment of the Descemet's membrane. And there's this paper in 2017 where Joe Mehta's group showed after a DALC operation, a split in the Descemet's membrane in two layers. So that misconception that the Descemet's can split was still being perpetuated or still being understood as a fact fairly recent. Now, what we showed on the basis of what I showed you first in the three types of bubble, that Descemet's membrane detachment occurs exactly in the same way as the three types of bubbles occur. And we published this in American Journal of Ophthalmology. And this is pretty much the evidence and the summary slide of that part of the clinical application in pathology. So, but we will show you more examples. So this type 1 bubble, and this is a Descemet's membrane detachment, which we have labeled a type 1 detachment. It is a detachment not of the Descemet's membrane alone, but the Descemet's membrane and the pre-Descemet's layer. And when the two detach, it appears as a very straight line. It's a very rigid line, like a tourmaline, and it is like the chord of the arc of a circle. So that's the circle, that's the chord. As against that, the type 2 detachments, this double contour line, you can see quite clearly, and sometimes it tears. And when it's torn, it curls with the endothelial cells outside. So that's a rhegmatogenous type 2 detachment. And you can get a mixed detachment. So you can see this. There's a pre-Descemet's layer, the Duer's layer is detached. The Descemet's membrane is also detached, and the two are also separated from each other. And this is not with air injection. This is spontaneous Descemet's membrane detachment that occurs in patients similar to what we showed with the air. So Descemet's membrane detachment is not a detachment of the Descemet's membrane only, It's a detachment often of the pre-Descemet's layer and the Descemet's membrane occurring together or having occurred together separated from each other, as we see in the mixed type. Now look at examples over here. Post-cataract chronic edema not resolving. Straight chord of a circle line. Then further down you can see, because it detaches over an area, and when you do your OCT scan, you can see here two lines are beginning to be seen. One is a straight line, and the other is a slightly curved. It's attached here and detached there. And then you actually see the straight line, which is the pre-Descemet's layer, Duer's layer detachment. And then the Descemet's membrane is detached and torn and scrolled. And here also it is scrolled. So this is a mixed rhegmatogenous detachment. It is of both the layers, quite clearly illustrated on this OCT example. And here's another example. You can see chronic edema post-cataract surgery. By the way, we all know that Descemet's membrane detachment commonly occurs post-surgery. And here you can see on a slit lamp, straight chord of a circle line. And on OCT, exactly the same is replicated. This is both the pre-Descemet's layer and the Descemet's membrane detached. Now, histological evidence is provided in 5 cases. So again, another patient here, that straight line. We did a PK on this patient, the penetrating keratoplasty, and you can see the OCT showed that chord of a circle appearance. And here you can see there's the Descemet's membrane and there's the pre-Descemet's layer. And in this case, the pre-Descemet's layer was completely acellular. Now, here's another example of a patient with a failed corneal graft. Again, a straight line. And here again, OCT, straight line. But you see this connection between the deep stroma and the anterior surface of the detachment. Now, we did a repeat PK, and you can see here again, this is the histology of the pre-Descemet's layer. The Descemet's membrane had been torn off from this. It had been detached during sectioning. So there's just the pre-Descemet's layer. But on high power, we can see it is populated with keratocytes. Now, when the keratocytes populate the pre-Descemet's layer and lay down more collagen, it becomes very taut, it becomes very stiff, and you cannot put it back with air. So we are now understanding how to manage these cases and why some of them fail, because they are very tight and they won't fit. The surface area is now less than the surface area against which you're trying to put them back. So you have to do a descematotomy, release with an addition and with an incision. And if the endothelium is still there, you can push it back. Otherwise, you have to change the whole cornea. So here again, another example of a mixed detachment. And here you can see clearly 2 lines. And these 2 lines are telling you one is a pre-Descemet's layer, one is a Descemet's membrane. And this one I showed you earlier of the rhegmatogenous type of a mixed detachment. Now, when we do dark, sometimes we see these strands that extend from the deep stroma to the anterior surface of the pre-Descemet's layer. And we have to even physically cut them sometimes or tease them off. Now you can imagine when spontaneous type 1 Descemet's membrane detachment occurs, which is the pre-Descemet's layer and the Descemet's membrane, then what you see is sometimes the strand, and I showed you one earlier. Here's another one. When you see this strand extending from the deep stroma to the detached Descemet's membrane, be sure that this is a type 1 Descemet's membrane detachment. And you can see there's another, this is the one I showed you earlier, the 2 different patients, and that straight line again. So the OCT morphology is now very clear which type of detachment we are dealing with. So this is classically a type 2 detachment. You can see the wavy line and the double contour line that we see of only the Descemet's membrane being detached. And if it is less than 1 millimeter, it is called planar. If it is more than 1 millimeter, it's called non-planar. And here's a very interesting example shared with me by Dr. Sangeeta Wagh from India. This patient of extensive Moran's ulcer, and you can see it developed a detachment, that straight line, and then they treated it, but it didn't heal. The acute nature of the Moran's healed, settled, but there was still the detachment over there. And you can see here it's very classically seen. They waited for a while. They were going to do a endothelial keratoplasty procedure for this patient. But interestingly, what happened is, despite the detachment being there, the type 1 detachment, The endothelial cells found the way there must have been little tears somewhere, and they grew on to cover the back of the cornea, and the cornea cleared despite this type 1 detachment. They could even get an endothelial cell count, and they then went and did a cataract operation without touching the detachment at all, and the patient got reasonable vision, 6/12 vision. So it gives a complete new dimension to this idea of desmus membrane detachment and how it might be managed. Now let's look at another clinical condition, infectious keratitis, deep corneal fungal abscesses, and we've all heard of intracorneal hypopures. The OCT imaging demonstrates that the collection is in the cleavage plane between the predesmus layer and the posterior cornea. Now, this was a paper published by Liu et al. In 2014, and they said that there was a PDL desmus membrane separation in corneas with severe fungal infection, providing pathological support for those finding an additional clinical meaning to the new anatomical concept. But what they showed was the fungi preferentially migrate along the anterior surface of the predesmus layer in the cleavage plane provided. And we've got now 3 or 4 cases like this, and you can see this patient of fungal keratitis. You do the OCT, and you can see that the type 1 desmus membrane detachment, and it's full of debris of inflammatory exudate in that space. And here's this example again, you can see of a type 1. So when you see a type 1 detachment in infectious keratitis, it's most likely to be fungal unless proved otherwise. So keep that in mind as a clinical feature, as a sign, the important sign in fungal keratitis, which was not known until we were able to show this over here. Now, we often see and talk about intracorneal hypopyon if you're doing a lot of cornea work in the countries where infection is common. So you see this over here. This hypopyon is not at the bottom of the limbus of the cornea here, which is much higher up. Now, where is that pus accumulating? And if you do OCT, as they've done over this, and you can see this image is, of course, horizontal, but you can see the pus is from here to here, and that space is clear fluid, and it is an intracorneal hypopyon. This part is like the type 1 detachment. So clearly, this kind of detachment will occur even in non-fungal keratitis, which is keratitis profunda, very deep, and intracorneal hypopures probably are collections in that space. Now, what about acute eye drops? Something we have for generations been told it is due to a tear in the desmus membrane. And in our very first paper on this layer, we had postulated, because we had some anecdotal evidence, that it is due to a tear in the desmus membrane and the predesmus layer, not just the desmus membrane. And here was the case on the basis of which we had made that comment. And you can see over here, the predesmus layer and the desmus membrane are torn and curled, and there are some keratocytes that have infiltrated. Again, you can see the predesmus layer, this is the desmus membrane and the predesmus layer with it. And that is this acute eye drops patient. Now, what you will see here quite classically is the 2 layers are separated. So you can see the predesmus layer, the desmus membrane, there's a big tear, and there is fluid vacuoles in the corner. So acute eye drops with a rhegmatogenous mixed detachment. So both the layers are torn. And here again, there's another case where there was a acute eye drops occurring in an eccentrically placed full thickness cornea transplant. And there too, we were able to show, even by slit lamp and OCT, the rip was in both the layers. This patient I showed you earlier was in a pellucid marginal degeneration case where there was acute eye drop. Again, you can see there are the 2 layers on the top that are separated, and then there is that strand which tells us that this is on the anterior surface of the predesmus layer. You will never see a strand extending between predesmus layer and desmus membrane. So again, evidence that both these layers are involved in acute eye drops. On the basis of this, Professor Murain said, well, if we oppose only the predesmus layer by mature sutures, we should be able to resolve eye drops. We don't actually have to try and get the curled desmus membrane open and stitched. And they went and did that. They put air to identify the extent of the tear, marked it, and put mattress sutures. And they were able to get a 40% reduction in the corneal edema on day 1 and 60% or more by day 15. So they could help resolve the acute eye drops quickly by only approximating the predestinate layer. Now, initially, Dr. Mellis, who we all regard very highly for his contribution to endothelial keratoplasty and deep anterior lamellar keratoplasty, he was not very sure about the existence of the layer. But lately, he published this paper that when they were trying to do Bowman's membrane transplant, sometimes in thin corneas, when they're making that pocket to put the Bowman's membrane, the instrument slipped or it penetrated internally and it tore the predestinate layer and destinate membrane from the stroma down into the AC. And in some of these patients, what they found was that they had destinate membrane detachment only, as you see on the top. And in these patients, there was no acute eye drops. But in those patients where they had torn the predestinate layer and the destinate membrane, they always got acute eye drops. So they actually confirmed, they quoted what we had originally reported, that acute eye drops is due to a tear in the predestinate layer and the destinate membrane. But we went ahead step further because we'd already done this experiment to show that if you take a normal cornea and you incise it and you put it on an artificial anterior chamber and you raise the pressure to 60 to 80 millimeters mercury, you don't get acute eye drops. So the deduction was that acute eye drops results from a tear in both the layers, but in the context of the abnormal collagen and abnormal glycosaminoglycans of a keratoconus cornea. So we responded to that paper by saying that it exactly what I just said, that it's the abnormal collagen and the ground substance which is seen in keratoconus is contributing to this as well. And they wrote back to say that they agree with that 100%. Now, what about keratoconus itself? So keratoconus is described as an ectasia of the corneal stroma, mostly caused by eye rubbing. Now, there is evidence to suggest that it is due to degradation of the elastin that is present predominantly in the predestinate layer in the normal cornea, and we'll just show you evidence of that. And when that starts to degrade, you're more likely to get keratoconus, and perhaps that's why often keratoconus starts as posterior keratoconus. And this was work by Keith Meek's group, who first showed, again, they were not so sure about the layer, but when they started working on it, they were able to show that the maximum elastin, they used a technique called on-face serial scanning electron microscopy. So they take a section of the cornea, they scan it, and then another section and scan it to build up a 3D image. And all the yellow is the elastin, and most of it was in the predestinate layer compared to the other part of the cornea. Now, what they also showed is that in keratoconus corneas, compared to normal, where there's a lot of yellow, there's hardly any yellow. So that the elastin degradation is a feature of keratoconus. And they can see there's hardly any yellow, very little over here. So we repeated this experiment using immunostaining for elastin. And what we found was, you can see that is the predestinate layer, the green line over there. And you can see that in keratoconus, there is none. So we also found there's hardly any by this other technique of immunofluorescence staining. So it is likely that the keratoconus pathogenesis is related to this disappearance of or degradation of elastin in the predestinate layer. And that's why maybe you get posterior keratoconus, and when it's degraded even more and it rips, then you get acute eye drops. And this is very interesting. For example, and just to confirm what I told you, if you take the predestinate layer on its own and stain for elastin, all that green is elastin, very dense. You stain the destinate membrane on its own, the elastin is concentrated to the more or less to the banded layer on the anterior surface. There's hardly any elastin in the thickness of the destinate membrane, only on the top. And this is the PDEC tissue, you know, the predestinate layer and the destinate membrane. You can see the anterior band over here on the destinate, and the rest is the predestinate layer. And that's the same from where partly the predestined layer has been removed. You can still see that band, like in the pure desmus membrane, and then a lot of the predestined layer has got elastin. And even if you look at non-separated tissue, which is just normal cornea, you can see the desmus membrane, no elastin, then the anterior band, interfacial matrix, no elastin, and the predestined layer showing you as a thick band of elastin, and then there's a corneal stroma. So it is present over there. Now, why does the desmus membrane always scroll with the endothelial surface outside, which is here? And my theory at that time, my hypothesis was that this elastin band on the anterior surface makes it roll towards itself. That's why the endothelium always is on the outside. Although people had said it is due to the elastin, but not what was not just the elastin, because elastin is also present in the predestined layer. That doesn't scroll in one or the other direction. It is the selective distribution of the elastin. And the others said that it is the swollen endothelial cells that are pushing it to scroll that way. So what we did this experiment and said, this is your DMEC scroll. If you put elastase enzyme that degrades elastin, that scroll on its own will start to open and become completely flat. And then when you do a section and stain for elastin, you can see the elastin is all degraded as compared to the control where it is normal. So it is this elastin band that is making it scroll, and if that is degraded, it unscrolls on its own. And the pedic tissue, if you take away the desmus membrane from the pedic tissue, which is the desmus layer and its elastin, it will not scroll at all. But if you two together, then it scrolls. So the scrolling of this pedic tissue, which is, like I said, the predestined layer and the endothelium and desmus, is given to it. That characteristic is attributed by the presence of the desmus membrane. Now, this is a little video. I hope it will work. Let's see. So if you take a rubber band and you release it, this is like your predestined layer, full of elastin, but when you make a type 1 bubble, it blows out and it comes back, just like that. You blow it out and it comes back. That is predestined layer. Now, if you take that rubber band and you put glue on it on the back surface, like I've done, and you stick it to a piece of paper. Now, this is the anterior elastin band on the desmus membrane, right? So you stick it over there and you leave it. Then what happens is that you will find when the desmus membrane detaches or tears, like that paper which the anterior band is stuck to, which is rubber band, it will, in slow motion, it will scroll with the blue endothelial surface on the outside. So that is why we now have an explanation for why this always occurs all the time. But like I say, God did not put elastin on the desmus membrane so that we can do DMEC. It is for a physiological role. And the physiological role is explained in this picture, that the desmus membrane is very closely applied to the back surface of the predestined layer. It has to be closely applied to pump out the water, but it is not physically attached by any structure, so that despite eye movement, rubbing, squeezing, the shearing stress doesn't come on the membrane. And this elastin band, which is on the anterior side, wants it to curl anteriorly, and that's what is keeping it firmly opposed to the back of the cornea. And I think that's the physiological role this elastin plays. Now, let's look at another pathology, desmetocele. Classically, we always said that desmetocele is an ectasia of the desmus membrane when all the stroma is gone. But look again, the more you look, the more you will find that there is a variable thickness of stroma excuse me, on it, and then that stroma will gradually melt, and then the predestined layer will stay on it for a while before that melts, and then the pure desmus ectasia occurs, which is more vulnerable to perforation. And what you see over here is this is the tear film, this line, but you can see that stroma is there. It's not just desmus membrane. And there is a lot of examples like that. And this is images lent to me by Muralidhar Ramappa from the L.V. Prasad Institute. And you can see pictures of how you can get only desmus membrane, or you can get desmus membrane with the predestined layer in your desmetoceles. So we've been told that the desmetocele can resist perforation for a while. That's true, but only if the predesmos layer is still on it. And some people now call this a predesmetocele rather than a desmetocele because it's not just pure desmos as we have always been taught and have always believed. Some couple of other examples of clinical applications. So you can see one of the colleagues, Natalia Zucker from Warsaw, shared this images by a colleague. This patient had a silver nitrate injury, and they did histology without any stain. And in the high power, you can see that the predesmos layer is not picking up any brown pigmentation. Rest of the cornea and the desmos endothelia pick up. So there's something that this silver nitrate is binding to, which is absent in the predesmos layer, and therefore you can see that differently. You can see the endothelial cells are here, and that is the desmos. So clearly there is something there which is different. We know that in lattice and granular dystrophy, the predesmos layer is affected very late. In macular dystrophy is affected very early. Macular dystrophy is supposed to be a endothelial dysfunction, and therefore the deposits will come more from the posterior surface. Again, telling us that the predesmos layer is more heavily influenced by the desmos and endothelium than the rest of the stroma, and therefore it will participate in pathology of the endothelium. And then there's another condition. This is published by Lish. It's called Lewis syndrome, where you get this biclonal gammopathy, paraproteinemia, keratopathy, and hypercopper. And it says you get a central discoid yellow brownish discoloration in the predesmos layer, is how they have described the pathology of this condition. So in summary of part one, the discovery of the layers introduced paradigm shifts in our understanding of the clinical pathology of a number of conditions. We talked about desmos membrane detachment, acute hair drops, keratoconus, spread of infection, desmetocele, internal hypopyon, etc. And we are working on how it might be involved in eye pressure control and glaucoma, and that will come later, and also perhaps in posterior corneal biomechanics. So let's go to the part two, the surgical application, a little more interesting. So we already seen this type 1 bubble. The important thing about it is that the predesmos layer is impervious to air. So a lot of air collects behind it. It doesn't go through it. The air injected in the stroma moves through the stroma till it reaches the predesmos layer and then lifts the predesmos layer up. So that's one important point. And you also notice that escape of air at the periphery. Now, that is what is happening in the eye when we do a DALK. So here you can see when we do a DALK operation, we're injecting air. This white ring is telling us the pressure exerted on the predesmos layer as it is separating from the stroma and reaches a point where it cannot separate, and then you get that white ring. As soon as you release the pressure by not injecting more air, that white ring disappears. So it's an optical phenomenon caused by that stretching of the fibers at the periphery. Now, if you go to the type 2 bubble, and we've seen this type 2 bubble already before, again, to mention, again, to re-emphasize this point that you get this escape of air at the periphery and this type 2 bubble forming. Now, how does it happen in the human eye? You can see what is happening here. Look at this bubble, very thin wall, no white line. And you see the bubble goes all the way to the periphery, way beyond your incision mark. So that is the area where the bubble has extended to. Now that is a type 2 bubble, and exactly happening in the human eye, what we were able to show in the human sclerocorneal disc ex vivo. And then the mixed bubble, I told you again, some people call it the type 3. And this is a video kindly lent to me by a very kind and famous Professor Katamish, who's in the audience. And you can see here, he's made a bubble and then found that there's another bubble inside, and he's cut that to show you that there's a desmos membrane now. So there's air trap between the stroma and the predesmos layer, and also air trap between the predesmos layer and the desmos membrane, which could be released by either making an incision or with a little pinprick at the periphery. So this is a classic example of a mixed bubble during DALK occurring in the clinical surgical situation. Now, you can peel off the desmos membrane from a type 1 bubble, and it does not burst. Unlike with the type 2 bubble, where the point I want to make is look at that roughness you see on the surface. Now, this roughness is on the anterior surface, the inside of the bubble, because it's those strands that extend between the predestinous layer, anterior surface, and the posterior surface of the cornea. Some of them are ruptured and are lying over there. Now, that roughness is there. Now, if you look at a clinical situation, again, it's a paper we published together with Dr. Katamish. These are images from his patients. The surface of a type 1 bubble is very rough. And I explain to you why. The surface of a type 2 bubble, pure desmus, is very smooth, homogeneous. You can hardly tell there is anything there. Now, when you see images like this, you know you got a type 1 bubble. Here, you know you got a type 2 bubble. This bubble is very vulnerable. This bubble is not. And you can get a very good outcome with either type of these bubbles, but you need to know which one. Otherwise, you could end up in problems. And for example, here, you got a mixed bubble. Now, if you're going to do a paracentesis to release aqueous after the bubble, as we routinely do, if it's a mixed bubble, you will burst the desmus. So the answer is don't do it that way. Wait till you release the air. Everything will go back up. And then you can go in because there's no tissue. It's not like this, but the bubble has become like that. So that is one important clinical tip. And if you got a mixed bubble which is partial, then you won't do a paracentesis from this side. You will come from the side where there's no desmus. Now look at this video. Just trimming the edge to make it clear and make it more smooth. The whole thing bursts on you. So this was a type 2 bubble, and we didn't know it at the time. And you can see the whole desmus membrane is torn. Now, if you have a type 2 bubble, never do anything. Always release the aqueous pressure by repeated paracentesis. The anterior chamber fills up very fast. So do a paracentesis, release the aqueous every 3 to 4 minutes during the operation. Keep releasing. If it is very tense, it's going to burst. If it is flaccid, when you touch it, it's not going to burst, just like a tense balloon. So multiple release of aqueous from the chamber to keep the membrane flaccid is the key to success here. So this is another video from Kana Ramesh. You can see they've done a dal, they put out tissue and they just increase the pressure by moving the eye and the whole thing bursts. It will never burst with a type 1 bubble. Only a type 2 which will burst. So once you recognize what you've got, your surgery becomes much more predictive because you will not be able to do maneuvers, or you will probably not do maneuvers that will lead to such kind of disasters. So in the beginning, when we didn't know about this, these were the things that were happening. If you get a type 1 bubble and you get a tear, it doesn't matter because that is not going to extend. And what you see over here, even a pretty large tear, I can put my probe into it, is over there. It will hold the aqueous and it will not cause the tear to extend if you put fluid inside. And you can complete your dal and then just put some air tamponade in the anterior chamber to support this, and it will heal properly. And you get a very good outcome. And all that this patient had to show was a little fold in the predestinous layer, desmus membrane, but the visual axis was very clear. So you can see, even with that tear, the operation could be successfully completed. But if it was a type 1 bubble, it's fine. If it's a type 2 bubble, it would not, because it will just burst on you. Sometimes this happens. Now, if you watch this video carefully, the mixed bubble forms and the inner one bursts. So you see that injecting air and a nice bubble forms, white ring, and suddenly it's gone. And there's air in the anterior chamber. So what has happened here, you look carefully and you can see that pointing out that circle there, there's a bubble that is trapped and it's not moving. So you proceed with the dal as you normally do. You take off the deep stroma. Here I'm injecting viscoelastic to make a space that has collapsed when the air escaped internally. And when you cut it out, you can see that you've got a nice type 1 bubble, but there's an area where there are 2 bubbles. And as you touch the edge, it's leaking. So the fluid was coming from underneath the rib. And when you did the operation, you put the air, and the next day what we could see is that there was only this line here, so telling us that the tear in the desmus had occurred underneath the host rib, that line over there. but we could successfully complete the operation having recognized what had actually happened, knowing about type 1, type 2, and mixed bubbles. This was a patient from Vinay Pillai from India. They did a very successful DALF in a 9-year-old child. There was no aqueous leak even, but the cornea never cleared. And OCT showed that they had a mixed bubble, and not only was it mixed, but it's a regmatogenous component to the descemet membrane, the type 1 component of the mixed bubble. So the pre-descemet layer was intact all the way, so there will be no leak, but the internal one is torn and scrolled, and therefore it will take weeks for this to clear or not at all. We then went ahead and did a PK instead of keeping it like that. Now, one thing very important to know is that the pre-descemet layer offers a cleavage plane, which is up to that 8 or 9 millimeter, maximum 9, but usually 8.5 in the center of the cornea. So that's the scanning the pre-descemet layer. You can see the pre-descemet layer continues the same whiteness as this. That's the edge of the descemet that has been cut. But that cleavage plane can be exploited to our advantage. So look at this video here. What's happening is we're trying to do a DALF. Air enters the anterior chamber because I've gone too deep. But that doesn't mean you abandon the operation. So see, there is air straight in the AC, right? So then you come another side. And now what you get a very small type 1 component. So you put viscoelastic, it slows down the rate at which the air escapes, so you can make that puncture mark. But you know that there is this physical plane, so you can physically extend it with a spatula. And now you reach exactly the end result as you would with the complete type 1 bubble. So once you have access to that plane, but the air will not go because there's a leak, so it won't make that bubble bigger. You put in a spatula and mechanically keep moving it, it will follow that plane by itself and be able to give you the kind of separation you want. So this one, just watch this video, how beautifully you can see the plane has been demonstrated by Rishi Swarup. They tried visco bubble. It didn't work in a keratoconus patient. So it was quite deep, the deformation. They were able to grab it and physically peel off the entire tissue, the cornea tissue, from the pre-descemet layer. So that plane can be exploited in more ways than one. Talking about viscoelastic bubbles, again, we looked into this in some detail. We're very surprised at what we found. Viscoelastic does not move in the stroma like air does. The more superficial you are with your needle injecting viscoelastic or with your cannula, as we show in this OCT image, the needle is quite superficial, it just spreads diffusely in the anterior stroma, which is much more compact than the posterior stroma. If you are in the mid stroma, you might find that it will separate in the mid stroma, the stromal tissue, and create an intrastromal big bubble. It looks very much like a type 1 big bubble. But look at the variable amount of stromal thickness that is left posteriorly behind. And it looks like a type 1 bubble. You can do the whole operation, cut the top, cut out the quadrants, everything, and it will look like you've done a good DALF, but you left behind a lot of tissue. And look at the needle depth in this. These are all ex vivo experiments in human eye that the needle was mid stroma. But if you are really deep, then let's get here. If you're really deep, you can get a nice type 1 big bubble, like you see here, or type with the pre-descemet layer. Or you can get, if you are not so deep, an intrastromal big bubble. So this will simulate or look like this. But this is what you want. This is what you don't want. And now people doing viscoelastic is that always do an OCT at the end of the operation. It'll give you a clear idea of how much you left behind. Again, we were able to show that if you want to burst this bubble, you have to inject air up to a 700 millimeters mercury pressure to burst the pre-descemet layer. And that enabled us to postulate that we could do a cataract underneath that. And it was, in fact, Mr. Ahmed Zaki who did the first triple DALF. So he did the DALF type 1 bubble, noticed that there's a cataract underneath. And he was able to do the cataract phacoemulsification with implant. In this patient, there was also PC tears. So he did anterior vitrectomy and did a sulcus fixated lens and was able to do all that under the pre-Desmitz layer. You cannot do this with the type 2 bubble because the Desmitz will tear straight away. But this triple dark operation can be done with a type 1 bubble. And Professor Katamish again has done this operation himself and got some very good videos on YouTube. These are some examples of that. And now this other surgical innovation, PDEC. So you can create a type 1 bubble, aspirate the air, and then refine the tissue, or you can cut it along the circumference of the bubble. So you end up with tissue which has the Desmitz membrane endothelium tamponaded with the pre-Desmitz layer. So you can see we're making that definition. The advantage of this is twofold. One is that it does not scroll as tightly as a Desmitz membrane, so it's easier to unscroll. And we know that most of the endothelial loss in DMEC occurs during attempts to unscroll it in the anterior chamber. So that you can reduce. And the other very important advantage of this technique is you can get a type 1 bubble at any age. And therefore, you can use really young donors which do not scroll as much, which you can't do with DMEC because it's very difficult to separate and get the tissue in young donors. And even if you get it, it's so tight that to unroll it, becomes a major challenge. So what you don't want is a type 2 bubble. And this is what we've got over here. So then you have to do a DMEC, you can't do a PDEC. So we were able to show, like I said, that this pre-Desmitz layer continues as the collagen strands of the trabecular meshwork. But while it is doing that, little fenestrations start to appear in the pre-Desmitz layer. So this is the pre-Desmitz layer from which the Desmitz membrane has been peeled off. So you can see that layer becomes the trabecular meshwork. But what is interesting, if you look at the high power, this is the example I give. So this is the same fibers making that scarf, but at the periphery, the tassels are your trabecular meshwork. And then there are these fenestrations which are close to each other before it becomes the trabecular meshwork proper. So if you create a bubble and it's a type 2 big bubble, then mark the point where it is starting and then complete the full type 2 bubble formation. And when you look underneath, you will find that there are these fenestrations. And these fenestrations can be about 5 to 60 microns in range in the diameter, but mean is 20 microns. There are 15 or 16 such randomly scattered around the periphery of the cornea. And now it explains why a type 2 bubble always starts at the periphery. So you can see these fenestrations are there. If there's the Desmitz membrane attachment over there, air is escaping, it will go into the anterior chamber. And we've all seen air going into the anterior chamber and down. But if the bubble is attached here, if the Desmitz is attached here, these air bubbles escaping through the fenestrations will go anterior to the Desmitz membrane and create a type 2 big bubble. That's the air that was escaping from the periphery of the ex vivo examples. Is this what's happening in the eye? So we use this knowledge to create this PDEC clamp. If you clamp those peripheral holes off, you only get air in the area you want, nothing escapes. So you never get a type 2 bubble, and all the air with a controlled manner, the controlled force is going towards creating the bubble. None is escaping. If air is escaping, you have to put more, force more in quickly to increase the intertissue pressure required to create a type 1 bubble. But when you have a clamp, it goes in a very, very controlled manner. And you can get a PDEC tissue. But there's another way of doing it, and this was the idea from Nicolas Pereira in Brazil. What they did is they went and scored the peripheral Desmitz membrane, just like you do when you want to get DMEC tissue. They scored it. So any air going under the Desmitz membrane is going to escape. It's not going to lift it up as a type 2 bubble. So by just doing that scoring technique, you can avoid a type 2 bubble. But the problem there is a lot of air escapes, and you have to increase a lot more the pressure with which you inject to get a bubble. And if it's too much, suddenly it will burst the Desmitz and you lose the tissue. So the clamp is still better, but you can avoid a type 2 by doing this scoring technique. And this is just to show you this PDEC operation as you can see, that the outcomes with OCT and visually announced slit lamp are very similar to that of DMEC. It is only 10 microns or so thicker than DMEC tissue, but the advantages are many, and you can get a very good clinical outcome. So that's the other surgical application. And in summary, therefore, this is for part two, that the existence of the layer and its knowledge and its behavior and understanding it has improved lamellar corneal surgery, particularly DALK and endothelial keratoplasty. It has made DALK much safer because now we don't get the disasters we had seen before when we know which type of bubble it is. It has led to the innovation of 3 new surgical procedures: the DALK triple, PDEC, and the surgical management of acute eye drops. It is involved in the pathogenesis of posterior corneal disease, and this is where the real innovation, and not only the innovation, but the actual clinical proof of the layer has come to the fore, because we, as I showed you, desmus membrane detachment, acute eye drops, completely changed our thinking. More work will come on keratoconus, which we are also doing, understanding of desmin to see the spread of infection. And I'm sure many more clinical signs will now be explained on how this layer behaves and how the inflammatory response behaves, okay, in relation to that plane of cleavage. And like I said, its role in glaucoma, in posterior corneal biomechanics, and posterior corneal curvature is being investigated. Thank you.
Thank you very much, Professor Dua, for this great lecture. And I'll open the discussion for the panelists before we take the questions. Professor Qatamish.
Professor Dua, thank you very much for this very highly specialized lecture about dual layer and its application. Just want to ask you about the occurrence of desmus membrane detachment type 1 in post-phaco cases you have shown. We know from our experience that dual layer is very firmly attached to stroma, and it couldn't be separated except by the force of air. And also we have noted during stripping of desmus membrane that the dual layer is very firmly attached to the stroma. So what is, in your opinion, the mechanism of separating this layer in post-phaco cases without the force of air?
So, your voice was not very clear, but I understand that what is the mechanism by which it separates without the force of air?
Yes.
In desmus detachment.
Yes, right? Type 1 desmus detachment.
Yes, in the type 1 detachment. So, when you get edema of the cornea, chronic edema, then this layer separates with the rest, and it's just that pressure allows it to separate. And then if it starts to contract, then the tangential force makes it separate even more, because that part, there's this plane of cleavage over there, which it is then separating along it. We say that we have to inject air with a lot of pressure to create a type 1 bubble, but most of that pressure is to force the air through the stroma to reach that plane. Once it reaches that plane, then you don't need that much pressure, because we are pushing the air to reach that plane. And if you try to inject viscoelastic, you have to inject so much, and it never reaches that plane, unless you're really deep. So the closer you are to the plane, the less force you will need. And the actual separation occurs quite easily. We have, even without air in eye bank eyes, separated the layer mechanically. Once you find the plane, you put a spatula, it separates it quite easily.
Thank you.
But chronic edema is associated with this type 1 or mixed desmus detachments.
Yes.
Sorry, Prof, may I ask a quick question, please?
Yeah, sure.
So first of all, thank you very much for this tremendous talk. As usual, I learned a lot from you. So I'm just trying to pull the topic slightly towards my area of interest. what do you think are the potential benefits of the dual layer in the treatment, in the possibly future treatment of glaucoma?
So if we can determine, we don't know the real answer. We're trying to do experiments now. We had some good experiments planned. We had a good grant, but because of COVID, we stopped getting a supply of whole eyes. But we are very convinced that the predesmous layer continues as the trabecular meshwork, and that is shown that even the peripheral cornea has basement membrane and trabecular cells in the last 500 microns of the peripheral cornea. So it's a continuum. It's not a separate tissue. So the trabecular meshwork is not a triangular structure that finishes at the attachment of the desmus membrane. In fact, the desmus membrane hardly has a single line attachment. It's a blend. So if the two are one structure, and we've seen how that structure can change in terms of its biochemical constituents, like elastin disappears, and other, the collagen molecules might be changing with disease, then its biomechanical effect on the trabecular meshwork will change. And if that is important, as we know, corneal biomechanics are very important in pressure measurement and pressure control, then it will impact. So there is that kind of a connection that on the basis of which you can make a case for investigating that relationship. And that's what we're trying to do.
Thank you.
Thanks, Prof.
Sorry, just to finish, there are a couple of posters on if you do deep sclerostomy, and if you are making that window closer to the peripheral cornea, and you leave the predesmous layer behind, the success rate is not as good as if you have taken it off as well. If you leave behind only desmus membrane in that window, you get much more oozing of aqueous through it. And they've shown this with the dye dilution technique. Take like a sidle test during intraoperative deep sclerostomy procedure. And then the ones that failed, when they went and looked back, I think you can look with OCT or even if you other means, I'm not sure what they think they use OCT. They were showing that, or was it eye-bank eye, that when they leave behind the predesmous layer and don't remove it, the success of deep sclerostomy is not that high. So again, there is that link with glaucoma over there.
Yeah, thank you.
Professor Dua,
Yes.
thank you very much for this interesting presentation. You always have something new to present about the dual layer. I have many comments, but because of the time limit, I'll just ask 3 questions. So regarding the triple DALC, do you find it safe to perform triple DALC, or it is better to postpone the cataract surgery after the DALC by 6 or 1 month or 1 year, putting in consideration that you are not afraid of traumatizing the endothelium as in PKP? You already preserved the patient endothelium. So why to do such a complex surgery with inaccurate biometry? You have a chance to do the DALC, and after 6 months, you can perform a very accurate biometry and do your cataract surgery safely.
Yeah, you're absolutely right. In fact, we have discussed all this in the paper, and the debate over when the patient needs both cornea transplant and cataract, which one do you do first, or do you do the two together? That there is no winner in that. All the points, like you say, are all valid, and I accept that. But the other way is also true. If a patient has got a cataract, and you can see the one that we showed in the video that Dr. Ahmed showed, he's having a major operation, hoping to get sight back. Now he's got still as blind as he was before the operation. Then you're going to wait after a DALC for at least a year before you can take sutures off and get the shape right. to do the biometry that will be stable to do the cataract operation. So the patient is blind for 1 more year, and if he's got both eyes visual impaired, he's been blind for a long time. So that has been the argument that why one should try and get visual restoration as soon as possible. And doing a cataract after a graft, no matter which graft it is, whether it's a DALC or a PK or particularly an EK or a PK, you always damage more endothelium than if you've done a graft after you've done the cataract. A lot of people argue that as the main reason why you should not do a PK or an EK before doing a cataract operation. And the endothelial loss will occur even with the DALC. Anytime you do a cataract, you get some endothelial loss. So the DALC will cause some endothelial loss, and the cataract will also cause some endothelial loss in 2 successive stages. So, like I said, the argument is there both ways. There are pros and cons, and you can make a justification for whichever approach you want to do. One first, the other first, both together. Phaco-DSEK, they have the same argument, whether we should do one first or the other first.
Okay.
Personally, you're right. I don't do a phaco-DMEK. I haven't done a phaco-DMEK yet. I always do the phaco first. You know, as long as the visibility is enough to see, do the phaco. Then at least wait for 1 month or longer before I come and do my DMEK. But I don't do a DMEK first in a planned case where I know I need a cataract and then come and do a cataract later because you get more loss.
Okay. Do you have an explanation why there is high incidence of double anterior chambers after type 2 bubble, even with intact descemet membrane? So if you have a type 2 bubble during your surgery and you succeeded in preserving
and your paper, you showed that for the first time with proper case, your case series of a large case series. So what happens, there, my thinking on this is that the descemet membrane is more flaccid than the PDL and the descemet. So the dome-like structure is maintained more with the type 1 bubble than with the type 2 bubble. So the type 2 bubble, if you're lying down on your back, even gravity wants the descemet to separate because the structure does not that maintain the dome. So there is a greater tendency for the descemet to want to separate from where it is than with the type 1 bubble. I think that is the case. But there's another argument where it might apply to both instances. So particularly in keratoconus, where the descemet membrane and the pre-descemet layer have been stretched so much that it is now the surface area is more than the surface area of the graft you're going to put on. Because as the keratoconus progresses, everything stretches. And when you do a DALC, whether it is a type 1 or type 2 bubble, you leave behind more of surface area of whatever you leave behind, whether it's PDL or DM, and you put in one which has the normal surface, not a conical stretched cornea. And now to get that to oppose, so much more tissue trying to be fitted against a smaller area is less likely to be a good fit. And then you should get a double AC with either type of big bubble in advanced cases of keratoconus in equal proportion.
Okay, my last question. Okay, my last question, is it possible to intend to have a type 2 bubble by injecting air in the periphery? Usually in eyes with macular dystrophy, the predesmatic layer, the Duas layer, is studded with the glycosaminoglycans deposits. So I usually try to have a type 2 bubble in these cases by injecting air in the periphery, but usually it doesn't succeed the same incidence whether I inject it in the center or the periphery.
Yeah, I think that is the holy grail of DALC surgery, to be able to predict which type of bubble, in fact, to be able to consistently get a big bubble. If there is a technique with which we can consistently get a big bubble, then we can try and figure out how to make it a type 2, not a type 1. But I have seen people, I think Dr. Katamish, only really great surgeons like you and Katamish can do this, where they've got a type 1 bubble and then they've opened it to create the plane and separate it and leave behind only. So you do it mechanically or physically, convert a type 1 into a type 2 in macular dystrophy. Now, it is very, very challenging procedure because you rupture the desmoid quite easily. But people have done that. And there's one other video by, I think, Dr. Shahbaz, and I think even Dr. Pogla has shown where you can actually peel off the macular dystrophy covered PDL from a type 1 bubble in dark. So I've not tried it, but fortunately we don't have that many macular dystrophy patients.
Okay, thank you.
The other thing, what we should also bear in mind is, if you have very flat cornea, when you have a very flat cornea and you are doing a DALT with a normal curved cornea, so now the fit is not right. And that happened with the macular dystrophy case with me. So there, the even the type 1 bubble will want to not attach because the contour of that is more flat than the contour of the cornea you're putting on it.
Prof, I've got a quick question. Like we showed in one of your cases, the PDL detachment after cataract surgery, is it something to do with the location of the incision? If it is more anterior, you will get more PDL detachment.
I don't think anybody has looked at that, but what we have seen is it is related sometimes to the cataract wound and sometimes to the side port. And you will see that the detachment is being pulled, the scar tissue is pulling it, and you can see even stray on it towards the incision of the side port in one case. In one case, it was towards the main wound. So often it's the main wound, and often sometimes it's neither of the two. It's just detached, but not particularly related to the wound structure. So if there is increased scarring, and like I say, tell people, like, example I try and give is if you have a wallpaper and you're trying to peel off a wallpaper from the wall, you can hold it at one end and pull, and it just comes off from the whole strip comes off from the wall. So you don't have to pull it backwards towards the roof, but you pull it down and pull it just slightly away. So that kind of stress, when it happens at the side port and you're pulling it, then the rest of it just peels off. And then, so that might be the kind of the way the forces work on the desmoid that cause it to peel off if there is scarring at the wound in which the PDL is involved. But the bottom line is that you cannot put it back. It'd be like a trampoline. You push it back with air, the air goes and it comes right back. So you have to make penetrations in it or incision to let it go back if there is still functional endothelium.
Thank you very much. Prof, one more last question from me. Like when we do the desmatorexis during endothelial keratoplasty, this damage that could happen to the host PDL, could it have any sort of implications, clinical implications or clinical consequences?
Usually, yeah, you're right. Usually it doesn't. But remember, many of these eyes, particularly in the UK, have got chronic edema. So the PDL is very loose. And I have one case which, Lana did histology for. We had done with a PDL rexus. We had removed, we said, this looks like a very thick desmoid membrane because we were removing desmoid, but we removed the whole PDL in that patient. So this PDL will be thicker. And if it's really chronic edema, it also becomes populated with cells. So, and it's very easy to damage it if you're using a bent needle rather than a scorer, which is bluntish. You can damage the PDL, and especially the more the edema and the longer it has been there. So that might have an implication for non-attachment or segmental detachment of the DMEC tissue or the PDL tissue, or PDX tissue. So I think you're right in that it does have a bearing, but how exactly that plays a part, in most cases, it doesn't, because we all do it and it works. But in these situations, I think it will make a difference.
Thank you very much.
And people have remarked, others have remarked on that as well, that sometimes you are actually stripping off the PDL.
Were you able to identify the dual layer by the confocal microscope?
Yes, but yeah, I mean, that's a paper we never published because remember, we were all involved in it and we found those black lines and stria, and we actually created a type 1 bubble in the eye bank eyes, and then we did confocal of that. So we know we are only doing confocal of the layer, and to have those physical characteristics and compare it with the whole eye confocal to show that these characteristics when you read. So that is something we've done that, and there is all that information is piled up somewhere. I think we started that even when Alomar was with us. It's never been written up, but
I still have some images, Prof.
Yeah, maybe we should write. Maybe you should write them. I can send you what I have, and then
sure,
you can
Prof,
at least do the confocal appearances of the PDL in a type 1 bubble. And then if you can do that in some of the normal eyes, I'm sure that when you do your volume scan all the way from front to the back, you will see that layer when you get to it, and those black lines become more intense in that layer.
Well, I got another question just quickly going back to cataract surgery, where you have in the middle of the surgery, you have full detachment of Descemet membrane. How do you approach that? Do you...
Sorry, what do you have in the middle of the surgery?
Like if you're doing cataract surgery and you have fully detachment of Descemet membrane.
Oh,
and
yes.
What's your approach? Do you try to correct the membrane first and then continue surgery, or do you continue the surgery, try to avoid touching the membrane? And do you think that membrane will survive at the end?
Yeah. So in these instances, it is mostly a type 2 detachment, right? And whenever you get a type 2 detachment after cataract surgery, you never get acute hydrops. So that's again links up with that same concept. So if it is most of the time, what I have seen is that it is in the area of the wound or in the area adjacent to the wound when you're trying to insert your lens or your phacoprobe in somebody who's got a bit of catata and an older, thicker Descemet. So you get that one, you leave it, it will recover by itself. Either the same Descemet flap comes back as the it's the wave of fluid. You just tap the wound and let the aqueous come out, and you'll find what is floating like this will flap back. And then you can put a bit of air if needed, but usually you don't. And then fill it again from the side port rather than from the main port, and that stays attached. But if it completely detaches, just give it a bit of time, the new endothelial cells will cover it. But when you have a large rhegmatogenous detachment, you have to protect it with a lot of viscoelastic to finish the operation. If you try to deposit it first and you haven't finished the operation, it will come off repeatedly during your procedure. So finish the operation first and keep topping up with viscoelastic. So if you're doing IA, so have like this soft shell technique. So more viscoelastic tamponading there. And it may not be completely unrolled, but you're still protecting it. And once you've done the cataract and put the lens in, then you start the procedure by using air injection and various maneuvers to unroll the Descemets. So that should be your final. And then you can even stitch it in place.
Professor Do, I have a rapid question for you, please. As you know, I have described what I call the collapsing big bubble. During my experience, rarely I have found that in some cases, while going out by the injecting cannula, I found that the bubble collapses. So I don't know exactly what is the cause for this phenomena. Is there any relation between the type of collagen or the type of pathology for having such a collapsed big bubble?
Yes, I've seen your videos. And when you put your cannula or your needle, the track that you make to inject the air, as soon as you pull it out, air comes straight out of that.
Yes.
And that hole or the tunnel that you made is in some patients stays that way, whereas in other it's like valvular. So like the stroma just compresses and doesn't let the air come out. So
yes,
it must be the structure of the cornea that allows that tunnel to remain patent all the way between the the space of the bubble and the exterior. It's difficult to tell, but if that happens, maybe you could top it up again and then press it before you take the cannula out. Like when we inject a DMEC tissue and we press the opening not to let it come back. You have to somehow try and keep the air in. But it's interesting how if you find the opening from where with your technique where you have a trocar and cannula, you find that hole again. You don't have to go all the way, just near where you start. If you put air, it will find its way back and give you some reappearance of the bubble.
Yes.
Yeah. And then try to put heel on and then put through the heel on,
Yes.
and then maybe it will stop it coming back out. So the heel on will collapse around the cannula.
Yes, the only solution.
It's rare. It's a rare occurrence.
Sometimes always collapsing, so the only solution is to inject a viscoelastic inside the bubble space. This will
you could, but the other thing you could do to prevent it, it's very difficult to predict which one's going to happen. But while you're going with your cannula, you go a little in a zigzag manner, just one twist. So it's not a straight line in and out, just a slight twist, then it becomes a valve and it stops it. So we have the same principle. Remember the paper we published on aqueous leaks in corneal perforations. So when you have non-traumatic corneal perforation, the internal hole in the desmus endothelium and the external hole point of sidal positive leak is not corresponding. And you will find there's layers of edema and the fluid is coming out from there where the internal hole is there. In those cases, the AC remains formed despite of positive sidal and it's leaking, but it's a formed AC. Whereas if you have a traumatic perforation, a wire has gone straight in and out, it always collapses the AC because the direct, not a valvular communication. So same principle with the air.
I have another observation from my experience that big bubble type 2 is always in cases of corneal opacity. So I have reached the conclusion that this may be due to the big bubble type 2 is always in cases with the corneal opacities, for example, post-herpetic cases or post-acanthamoeba cases.
Yes.
So I think that if you agree with me that the explanation for this is the space between the dual layer and the stroma is occluded by the scarring. So there is no place for the air to go except for the predesmatic space.
Yes,
is it right?
I think you're right. I agree with that because in scarred corneas for mostly infectious reasons, the layer, as we've been showing in some of these cases, does get scarred. It normally predominantly acellular, but keratocytes can migrate into it. And once that happens, then the cleavage plane is lost. And if that cleavage plane is not easily separated, the air will continue to find the peripheral holes and then go into the deeper plane. So that's probably the reason why. Yeah, I agree. Some kind of scarring or post-inflammatory response, and then it impedes access to that cleavage plane.
Yes. Thank you.
Okay, there was a question on the chat. There was one or two questions, I think, on the chat. So somebody asked, what does it mean type 2 bubble? And I think somebody answered it and said, I think. So clearly, some people need more explanation from the basic. I avoided all that, assuming that everybody knows by now what is type 1 and type 2, but we forget that every year a new generation of ophthalmologists is coming who may not have been taught about this. And so they need that kind of education as well. So sorry, my apologies to, it's called, I think it was Madeline and Tara Hassan, that I did not explain what is one type and what is the other, but ask any of your senior colleagues and they will tell you what the answer is. And yeah, so that was the only question.
Okay, great. I think we came to the end of the session, and I would like to thank Professor Harminder Dua for the amazing presentation, which was systematic as usual and educational. And I think we are approaching the midnight time in Delhi, so he is tired after the long travel, and sorry for that, Professor. And really, we are grateful that you devoted some of your time to educate us. And at the same time, I'd like to thank all the panelists. And special thanks to Professor Tariq Qatamish, who actually was the main engine behind generating, with Dr. Nancy Raqad, of course, generating the 2022-23 Cornea series. And thanks to all of you, of course, for being with us, and have a good night.
Thank you.
Thank you.
Thank you very much.
Bye-bye.
Thank you, Professor Dua. Bye-bye.
Bye-bye.